Good morning, good afternoon, and good evening, everyone. And thank you for joining us for the webinar, Combating Ageism as a Policy Lever in the Delivery of Vaccines in Long-Term Care Facilities. My name is Anusha Khan, and I'm a project officer at the IFA. Today's webinar is the second in the three-part series called Driving Adult Vaccination Policy, which is a series of interactive policy dialogues built around issues for which immunization policy and action will improve and save the lives of potentially millions of older people. We are honored to be joined today by key experts, including Professor Liat Ayalon, Dr. Louis Miguel Gutierrez, Dr. Peter Lloyd Sherlock, and Dr. Jane Barrett. We will begin today's session with opening remarks, followed by presentations from the speakers, and then a moderated discussion. Please use the chat function at the bottom of the screen to ask any questions that will then be discussed in the moderated discussion. This webinar will be moderated by Dr. Jane Barrett. Dr. Barrett is the Secretary General of the International Federation on Aging. Her leadership drives the agenda for the world's population aging within the UN Decade of Healthy Aging. Among her many current positions, she is a member Vision Academy, Director Baycrest Health Sciences, member International Council for Adult Immunization and Task, and member World Economic Forum Global Agenda Council on Aging and Longevity. Thank you, Dr. Barrett, for joining us today, and it is now my pleasure to hand the floor over to you.
And thank you very much, Anusha. And as you said, good morning, good afternoon, and good evening to all. The International Federation on Aging for over a decade now has been working to improve the global adult vaccination uptake rates by helping to influence policy and practice change. The IFA remains extremely concerned in the midst of this pandemic. There is insufficient policy dialogue around improving adult vaccination coverage through an integrated approach at the country level. And this should be informed by the UN Decade of Healthy Aging, the Immunisation Agenda 2030, and the WHO Global Report on Ageism. Targeted towards civil society, government, and intergovernmental agencies, we are convening this webinar today, with the overall title, Driving Adult Vaccination Policy, to be built around issues for which immunisation policy and action will undoubtedly improve and save the lives of potentially millions of older people. Combating ageism as a policy lever in the delivery of vaccines in long-term care facilities is the overarching theme of this particular webinar, and we are very proud and honoured to have three of the world's leading thinkers in this particular area. As Anusha said, there will be three brief presentations followed by a moderated discussion. And the first presentation is by Professor Liat Ayalon, Professor in the School of Social Work in Israel. Each of the presenters have agreed for their brief bios to be put into the chat box, but let me tell you that IFA and I have worked with Liat for over many years, and she is a key expert in the area of ageism. As I said, Professor in the School of Social Work at Bar Ilan University in Israel, she coordinates the international EU-funded doctoral program on the topic of ageism. She is also the Israel Principal Investigator of the EU-funded Mask Age program to study aging masculinities in literature and cinema. We welcome Liat, Professor Ayalon, to this important webinar, and thank you for kicking off this important discussion. The floor is yours, Liat.
Thank you very much for the opportunity to be here today. I think this is an extremely important topic, and I'm honored to be here. I will be talking about ageism in vaccination policies of older people in long-term care settings, and I will start by setting the floor and defining what ageism is. And basically, ageism is a bias in the way we think, which are the stereotypes, the way we feel, prejudice, and the way we behave towards people because of their age. And it can be both positive and negative and can be directed towards people of any age group. This presentation, however, is going to focus primarily, but not only, on the negative aspects of ageism as they have been manifesting in various ways during the pandemic, and the focus will be again on vaccination in long-term care setting. I will start out by saying why I think that simultaneously with the pandemic, we have seen another pandemic, which is the pandemic of ageism. And the main reason is the fact that age has been identified as an independent risk for severe illness and mortality due to COVID. And this has resulted in the portrayal of older people as vulnerable, as weak, and older people also as a burden to society, especially at times of scarce resources. And we will get to that further along this presentation when I get also to vaccinations. This also has resulted, especially during the early stages of the pandemic, in generations pitting against each other, and in a major disregard of instructions related to the pandemic, including vaccination, among certain age groups, thinking that this is not their disease because the entire disease has been portrayed as a disease of older people. We have seen actually horrific instances of ageism in a variety of policy measures all over the world, both with regard to lockdown strategies, exit strategy, triage, long-term care, and vaccines. And I will be talking mainly about long-term care settings and vaccines and how ageism has played a major role in these two areas. And I will start by long-term care settings. And basically, I think that early on, we heard horrible stories from all over the world. And this has been really, I would say, worldwide phenomena of residents being locked for months in their units, residents abandoned in some places, bodies hidden for days, and a lot of discussion about limited workforce and personal protective equipment. We hear these stories now again with another major wave that is on its, I guess, way or its peak. Again, the limited workforce and the limited PPE, for instance, have been there all along. Also, the paternalistic approach that I will be talking about a little bit during this presentation. All of these things are not new. What is new is that we are now facing a period where there are really scarce resources. This is an emergency situation, and everything has been escalating. And I will give a couple of examples from a study that we conducted in Israel in long-term care settings, where we interviewed both residents and their family members about their experiences. And what we have heard over and over was both reports of functional declines and reports concerning depression, anxiety, and PTSD, post-traumatic stress disorder, that has evolved as a result of this month of lockdown, in order to supposedly physically protect older people at the expense of their emotional well-being and their medical care for all routine activity. This also has resulted in family caregivers reporting high levels of worries, guilt, but also some of them were reporting a sense of relief because they really felt like they couldn't handle caring for their loved ones at home during this terrible time of the pandemic, and they felt that as if these people are protected in long-term care settings. This flyer, however, was sent to me yesterday, and basically what it says is no more, which means that even now, during the fifth wave of the pandemic in Israel, we are hearing the exact same stories about residents being locked in their units and visits being banned. And this is despite the fact that it was very clear both to administrators, both to policymakers, and to residents and family members themselves that the situation was not healthy for older people. And even though they managed to so-called protect them physically from the pandemic to some degree, they have failed to protect their mental health and health status. This is another incident, another picture that I want to show you that actually is taken from the Israeli Ministry of Health. And the reason why I think this is a picture that again portrays ageism is because that what you see here are graphs concerning the sickness among children with regard to COVID. There is no report as detailed as this with regard to older people, And there is no mentioning whatsoever on the dashboard with regard to long-term care residents. This is extremely unfortunate and really shows the oversight of the Ministry of Health, especially because we know that most of the severe illness and death come from these settings, which are completely disregarded. And the Ministry of Health in Israel actually has been supplying the data, I think, to guide policies all over the world. So it's not like we're not collecting data. We are monitoring everything, yet it's not on the dashboard. So that's another example of how ageism plays a part with regard to long-term care older people. If I move to vaccination, and I will talk about ageism with regard to vaccination, COVID-19 vaccination, we see here in a couple of different studies that older people have been neglected and have not been part of the initial trials to test the effectiveness of COVID-19 vaccination. This again is not a new phenomenon. And if we look at diabetes, if we look at heart condition, if we look even at dementia, we will see that older people have been neglected from these clinical trials all along. So what we are seeing now during the pandemic has been going on even before. Diseases that are specifically related or specifically severe in the case of older people do not receive this, or are not, older people are not part of the test group during clinical trials. So this again is another example of how ageism plays a part, this time in COVID-19 vaccination. I'm not even talking about long-term care residents and their participation in these trials. If we go to the public sentiment, I will now briefly demonstrate that by a study that we conducted that looked at a single newspaper article that was published over a year ago in December 1st, on December 1st, 2020 in the New York Times. And this article really outlined the CDC guidelines with regard to the prioritization of vaccination in the United States. We actually were interested in how the public feels about these guidelines and how the public views the priority of older people vis-a-vis these guidelines. So what we did was to look at the commentators and how they frame old age within the context of a limited vaccine. What we found was that overall, the commentators used two major themes to classify those who deserve to be first in line versus those who should be last in line. The first one was contribution. And those people who were seen as contributing more to the economy were seen as the ones that should be first in line. And then there was also the aspect of vulnerability. And those people who were seen as vulnerable to the disease also were thought to be first in line, but certainly it was mainly the social contribution that played the most part. Another thing that we have seen in these commentators' comments was a lot of self-ageism. And I'm giving here one quote of a 70-year-something couple who is saying that they want, I want our frontline healthcare workers to be first in line. And basically they're saying we can wait a few more months, even though we are 70-year-old. And then the responses of the public, of the other commentators, was, "You're wrong, thank you," meaning frontline workers, the ones who are taking care of the economy, should be first. We try to portray how the public thinks about prioritization, and basically essential workers were seen as deserving to be first. Sorry. Because they both contribute to the economy and are vulnerable. Long-term care workers are vulnerable. Sorry, long-term care residents are vulnerable, but their social contribution is minimal. So their priority is a little less. Older workers cannot shield themselves. So they're both vulnerable and have a social contribution. To summarize this study, I would say that we have seen calls for generational sacrifice during the pandemic in a variety of studies. And these calls have been quite evident in people's comments. And both ageism and self-ageism were highly evident. One thing that actually we found extremely interesting was the neoliberal framework that really prioritized the contribution to the economy. I have to say that as an Israeli, I was surprised by that. I thought this was very American because in Israel, there was no discussion whatsoever about prioritization based on social contribution to the economy. It was only based on vulnerability. Another study that I will be talking about briefly looked at benevolent versus hostile ageism. And this study again tried to predict and see how people conceptualize prioritization with regard to vaccine, with regard to treatment at times of scarce resources. And the difference between these two concepts are that benevolent ageism also has a component of thinking of older people as warm, whereas hostile ageism and benevolent ageism both characterize older people as incompetent. So again, it's this idea of being incompetent, being vulnerable, versus being warm and maybe having some contribution. And those people who were holding benevolent ageism actually were more likely to prioritize older people's healthcare needs. So it really shows that there is a difference. And when people think a little bit differently about older people and not only as weak or incompetent, then they are more likely to prioritize the care of older people. I will say that again, these things are not surprising. And way before the pandemic, it has been suggested that at times of scarce resources, older people are expected not to consume too much and to move away and give the right of the way to younger populations. And we have seen that in a variety of ways, also with regard to the vaccine during the pandemic. The problem with these messages, the problem with these communications is, as you have seen with the commentator study, is that older people actually internalize these messages and operate according to them. And when people think of themselves as a burden, as vulnerable, it's going to shape their aging experiences. And now we already have a generation that has been exposed to these messages over and over for over 2 years. I'm going to let Peter Lloyd Sherlock talk a lot about ageism with regard to the prioritization of the vaccine in real life. I will just say that this is really a case of either positive ageism or negative ageism in some countries like Israel, also the United States and others. Older people receive the priority, both with regard to vaccines, with regard to tests now. In other countries, such as China, for instance, older people over the age of 60 were banned from receiving the vaccine. And this is a case of negative ageism, of course. To conclude, I will say that I'm all in favor for positive acts of ageism in the case of older people, in the case of long-term care residents and staff. And I believe that they should definitely receive the priority with regard to tests, with regard to vaccines, and also with regard to monitoring, which, as I showed you, is currently lacking. I think that we do need to move to a change in terminology, and we're not there yet. And we need to change terminology from thinking about long-term care settings to thinking about long-term care homes. I initially changed my presentation and put long-term care homes all over, but then I realized that what has been happening in the past 2 years is not a reflection of home. It's a reflection of settings, of institutes, where other people make decisions for you and are very paternalistic towards you in order to so-called protect you at the cost of compromising your health and mental health in a variety of other ways. So I think that we do need to change terminology, but it's not only a terminology thing, and we are not yet there, and we definitely have to go in that direction. I will also add that the pandemic is not a reason for human rights violations, and certainly the human rights of all of us during the pandemic have been violated. But the ones that have been ignored most of all, the ones that have suffered most of all, from human rights violations are long-term care residents, and this must change. I also would like to make a call for a UN convention for the rights of older people in order to lead us, to lead the nations in terms of rights and wrongs with regard to older people, because obviously every time we are facing an extreme situation such as this pandemic, things are getting out of hand and human rights are being compromised. And I will end by saying that I think that the campaign to end ageism is more relevant now than ever. And I met Jane 6 years ago in 2016 when the campaign just started. And I think that I was extremely optimistic with this new vision for a word for all ages. During the pandemic, my optimism has dwindled substantially, and I've lost hope. And now I'm starting to hope again. And I think that maybe this is the event that will shake all of us and will make us realize that we do have to change the way we feel, think, and act towards age and aging in order to create a better society. I wanted to thank you for your time, and I apologize for coughing because I actually have COVID despite being vaccinated. So these are the effects. Sorry about that, and thank you.
Look, thank you very much, Liat, and a gratitude for you being with us today. Just deep gratitude. Look, I'm actually speechless that you've come with us when you're quite unwell. So thank you very much. I think, Liat, what you've really set the scene is to remind us about the three aspects of ageism: institutional, interpersonal, and self-identifying. And quite correctly, you've talked about the fact that, we in the business of studying and growing older understand that ageism was very much present pre-COVID, and COVID has really brutally exposed examples that are imprinted in our minds and in our hearts, around the world. But that doesn't seem to have actually helped us shift forward in the dialogue around ageism. And a question that I'm going to be asking you when we go into the moderated session is, how can we actually pull through adult vaccination in the context of the UN Decade of Healthy Aging? Because as we will hear from our next speaker, it's very difficult to bring unlike disciplines together around a common agenda called improving adult vaccination. So I would be very interested, how can we do this? So once again, thank you very much for being with us today under such circumstances. It's now my great pleasure to introduce Dr. Luis Miguel Gutierrez Robledo, Director General of the National Institute of Geriatrics, National Institutes of Health, Mexico. Luis Miguel is a great friend and colleague of me, but many people around the world. And whenever we meet, whether it's a face-to-face meeting or whether it's Zoom, there's this almost camaraderie around what we're trying to do in this world of geriatrics, gerontology, and the study of aging to improve the health and well-being of older people. Dr. Gutierrez is a Mexican scholar trained in France on geographic medicine, geriatric medicine, could be geography as well, and the biology of aging. And he currently serves as Director General of the National Institute of Geriatrics at the National Institutes of Health in Mexico. He is the expert lead of the Mexican Aging and Health Strategy, and with international experience and high expertise, he has become one of those doyens and highly respected experts in the field of public health and aging. Luis Miguel, I see you, in PAHO meetings, at WHO meetings, listen to your lectures at the European Academy for the Medicine on Aging and the Latin American Academy for the Medicine of Aging. What I know of you, Luis Miguel, is that, whenever we come to you, for questions, whether it's about pertussis or whether it's about ageism or whether it's about, vaccination in Latin America, you're one of those rare individuals that is very ready to have a chat and impart your knowledge. So that's why we're very honoured to have you with us today. So, sir, the floor is yours.
Thank you so much, Jane. You're so kind and generous with that introduction. I'm very honored to be here sharing the floor with you all. And after the wonderful presentation by Elia, well, I will try to focus in a rather medical point of view what's been going on in this last couple of years. Just at the beginning of the pandemic, the focus was on older individuals from the outset. This is a paper that was published very early and at the beginning, where COVID was seen almost as a disease of older people from the scientific world. This is quite interesting to see how this was focused at the beginning and how it has evolved later on. In fact, it's understandable at the beginning when we look at the toll of deaths and how it happened at the very early months of the pandemic, and how almost half of the deaths in the first year happened in older people living in long-term care facilities. And this is also extremely important to focus on what I am going to address in the next few minutes. And this is how knowledge has been developed in order to develop the vaccines and to test their efficacy, and what's coming next in the next few years, because maybe this pandemic is ending, but we will have many others in the future. And challenges for vaccine developers and for policymakers will remain there. Now, inducing protective immune responses in older populations against a new pathogen is quite an issue. And we have realized how difficult it is in this context, mainly with frail older individuals, which are prevalent mainly in long-term care institutions. But there are challenges on assessing the vaccine safety while we are confined in our homes and in the institutions and less exposed to the risk. So it's also very difficult to test the effectiveness of a vaccine in such a scenario, and then determining what data support expanding vaccination to all ages. And here I would like to talk about ageism, not only directed against older individuals, but in a more broader perspective, because there have been discussions from this perspective as well. And at the end, how to successfully distribute vaccines to older populations with historically low uptake, particularly in regions like Latin America in long-term care, in the long-term care context. But the main issue from this perspective is because of the potential for this population and those living in particularly in low and middle income countries to respond less effectively to COVID-19 vaccines, strategies should have been implemented early in vaccine development programs to optimize effectiveness in these vulnerable populations. But up to now, this has simply not happened. We have been very lucky, extremely lucky. But in fact, this paper shows how things are moving. The efficacy of the vaccine in older adults was simply unexpected, unanticipated. We didn't know that it would be useful. It happened to be, and we have been fortunate from that point of view. In particular, this paper refers to one vaccine, but later on, as we have seen knowledge emerge about other vaccines, we are comfortable with their efficacy in the older population as a whole. But when we go deeper into this perspective, and when we look specifically at nursing home residents or at frail older individuals, we realize that immunosenescence is a barrier, and that frailty is a barrier to an optimal response to the vaccine. And we know, in fact, that the COVID-19 pandemic As it was stated in the Lancet once, it's not a pandemic. In fact, we are facing a syndemic that puts in the forefront the issue of inequality as well. And this is a multiplier of inequalities, especially towards the older population. And it has been a silent massacre, as Peter has said very well. And frailty is the most challenging expression of population aging in this context, with major consequences for public health and clinical practice. Physical frailty is an effective health indicator, and it has previously shown to predict a response to the seasonal flu vaccine, for example, and now it is the case also for COVID. Assessing frailty in older individuals may identify those who are less likely to respond to immunization and so at higher risk for COVID and its complications. A worldwide research and development blueprint was initiated to accelerate the development of vaccines and therapeutics for this outbreak, but even considering the above, very few recognize the importance to take aging into consideration about future vaccination and treatment interventions, focusing on the possible impact of frailty. And then this paper came when the vaccination initiative began, very few weeks after, in the month of January last year, coming from Norway, the awareness of seemingly a high risk of vaccinating older people in long-term care institutions because they would die because of side effects of this vaccine, and it raised concern among the committees and the governments, and it was in the public discussion in the media as well. Soon we realized I've been the head of the side effect vaccine events in Mexico, and at the beginning we were concerned, but soon we realized that it was an overreaction, and that in fact it was not that risky to vaccinate older people, even frail older people in institutions. Now we know that despite the toll taken by COVID-19, the increased risk of adverse outcome noted above and the potentially negative impact of frailty on the response, frail older adults should be vaccinated, but we would have been aware of the benefits of this vaccination from the outset, and we would not have been so concerned if they would have been included from the beginning in the clinical trials for the development of the vaccines. In fact, in long-term care facilities, as Layat has said before, ageism has multiple phases that can manifest through ignorance of the care needs of older people, social exclusion, failure to recognize the potential for improvement within the people who live in these care homes. And there is a very scarce research and very few national data sets, as it has been already stated, on long-term care worldwide. It was very difficult for me to find information about this issue, other than the website from the London School of Economics that I showed before, and the website developed by Dr. Lloyd Sherlock. There is very little information, and a perception that older generalized perception that older people in need of long-term care are a burden, and an institutional culture that doesn't support person-centered care. And as it was said before, maybe I will not stop here because it has already been said by Dr. Ayalon, and this paper has already been shown by her as well, and Dr. Sherlock will talk about this once again. But now I would like to turn to the issue of prioritization of vaccine. And in fact, all around the world, the only country that I could find that stated clearly and definitely the priority for residents in a care home as the first priority risk group was the United Kingdom. I'm not aware of any other country in the world taking this approach. And this is, as far as I know, the only, at least the only country that states it as clearly as this. This is the prioritization that comes from the WHO SAGE roadmap for prioritizing use of COVID-19 vaccines. Older adults are put in the first place, but in the whole document, not a single mention of long-term care is made. Not a single mention. It's an issue that is never addressed by the SAGE expert group on vaccination within WHO. Several initiatives have been developed in order to follow up the flux of vaccines towards the long-term care institutions, such as the COVID tracking project from the Atlantic. But as early as March last year, this initiative stopped. And in the CDC, another information system was created, but the last time it was updated is April last year. And ever since, no information is available at this website. It's amazing, but you want to see this information, and it's not possible to know what's going on. Only recently, 3 weeks ago, the OECD published this report in which they address the issue. It's interesting and it's positive in many ways, because in fact, I felt relieved when I saw this paper, and I found it only yesterday, and it was very interesting to see that, in fact, the data coming directly from the countries and reported to the OECD, it makes us think that, in fact, the 28 countries that contributed with information prioritized care home residents. But this is something I am learning only now, and that is not easy to know for most people, because the information is not easily available. In some cases, people receiving home care could receive the vaccine from the GPs and could be accompanied to the vaccine site by home care personnel, for example, in Australia, and in other cases such as Denmark and the UK, household people could receive the vaccine in their homes. That was the case also in Mexico, not in Mexico as a whole, in all the country, but in Mexico City in particular. And the vaccination impact in long-term care that you can see from this report is interesting to see as well, how in Chile there is evidence of a very good impact of the vaccination campaign, as well as in the US and in Spain. And reports are being published recently, particularly the one from Israel is very specific about the context of long-term care and the benefits of the vaccine in this very, very particular population. And I believe that now the evidence that we have about the benefits and the impact of that vaccination in this context can give us some optimism, as Dr. Ayala said also. I was at the beginning very negativistic, but now I feel that we have an opportunity here, and that there is a great opportunity to move forward, taking advantage of this issue. If we consider the perspective of the professionals involved in the care of older people, Ken Rockwood published this image and this analysis, talking about the potential contributions of geriatricians in the different steps of vaccine development. Only last week, I talked to Dr. Alejandro Cravioto. He's Mexican. He's a colleague of mine, and he's the current lead of the SAGE group at WHO. And he confirmed that no single aging expert works within the SAGE group at WHO today. But I think that being aware of what is happening nowadays opens an opportunity to begin having an impact within this and other expert groups around the world. Because recent technological advances are allowing us to decipher the mechanisms of immune senescence. And I think that there's a big opportunity as well to move forward in the field, not only from the perspective of vaccination, but much more deeper going into the understanding on how we age and how our immune system is modified by conditions such as frailty. The tools that have been developed will enable us for a greater understanding of why some people respond more effectively to infections such as SARS-CoV-2 than do others. And defining these mechanisms of effective immunity will be critical for protecting vulnerable populations against future infectious disease outbreaks. So yes, we face a terrible crisis, but here we have a great opportunity as well. Thank you.
Thank you very much, Luis Miguel. I think, you know, a central theme that comes out in both of your presentations is about data. You know, either the lack of data or the lack of disaggregation and the sources of data, you know, and the reliability of the data. And it wouldn't be surprising to any of you on this call or our presenters that we don't collect, WHO doesn't collect data on long-term care, vaccination and long-term care. And that's certainly a gap that IFA, you know, is doing a bit of work in at the moment. You know, we don't really know what vaccines are administered, by whom and where, and to whom in long-term care facilities. I think I'm so delighted that you have been talking with the chair of SAGE, because that's another area that has concerned IFA for a long time, the lack of representation. Because if there's not leadership from SAGE in terms of the composition, then at a country level, the NITAGs, the same happens. You know, in a study that we've just completed, you know, 1 out of 20 NITAGs has one representative, you know, on the NITAG. So when we're looking at a comprehensive life course approach to immunisation, while I'm not saying that it's biased, we have to actually ask ourselves, who are the experts on these NITAGs and to what degree do they have the expertise in, you know, older people and the immune response and the effectiveness of vaccines. So I think that's another area, Luis Miguel, that we must pay attention to. So thank you very much for that. It's now once again my great pleasure to introduce Dr. Peter Lloyd Sherlock. And, you know, when I'm thinking about introducing, you know, colleagues, you know, the words of fearless, courageous come to mind when I'm talking about Peter. You know, Peter, in the very early stages of the pandemic, stepped forward, you know, and started creating, you know, an informal expert network with little or no money. And that's the kind of person Peter is, because he's at the front, being the activist, but being a thoughtful spokesperson and being able to interpret complex research, you know, so that we create a narrative that's meaningful. So Dr. Peter Lloyd Sherlock, his research focuses on public policy and older people in low and middle income countries, including health and social care. He is currently leading major research projects related to COVID-19 and older people in Brazil, South Africa, Mexico, and Argentina. As I've said, Peter runs an informal expert network on related issues of COVID and older people, and is a member of the WHO's Clinical Consortium on Healthy Aging and the Lancet Commission on COVID-19 Humanitarian Relief, Social Protection, and Vulnerable Groups. And, you know, when we introduce Peter, then I think about these clinical consortiums where, you know, I meet Luis Miguel and also Liat. So it's colleagues coming together towards a common agenda, coming at this problem from different perspectives. So Peter, thank you very much for being with us, and the floor is yours.
Thank you very much, Jane. I'll just see if my slides are sharing.
Yes, you're right.
Yeah, they are. Great, fantastic. Okay, well, I've been asked to focus on these issues broadly with reference to what are called low and middle income countries. Some people still refer to them as developing countries. Before I focus more specifically on long-term care, I would like to make the point that I think what goes on in terms of long-term care facilities in low and middle income countries has really to be understood within a wider context, which we've already hinted at in the previous two papers today, which were excellent, which I would describe as global geronticide. And I would use that term as an academic as much as an activist. I feel that what's been happening in many parts of the world in terms of excluding older people from COVID vaccination is arguably the greatest public health scandal of the century. And I am also appalled by the lack of attention it has received by the global media and by many global international organizations. And I think this is my mother who has dementia who's phoning me, so I will have to take this. Hello, Mum. Mum, I can't talk. I'm actually in the middle of giving a talk to lots of international experts. Can I call you back? Super. Okay, bye. It's great when you talk to gerontologists and geriatricians because they understand. Where was I? Yes, going back to my slightly more serious tone. So, I mean, in some ways, I think, as is often the case with great global scandals, I think the silence of the international community is actually permitting this to take place and to continue. They're facilitating what I consider to be the greatest global health scandal of the 21st century. That's a very strong claim to make. Here are some examples of what I mean.
Peter, can you put it into full screen mode?
I'm trying to actually, current slide. Ah, great, there we go. So these are the latest data we have for Bolivia, which apparently has provided more doses of COVID vaccine to people under the age of 30 than over the age of 60. Here are data for Bulgaria, the latest we have for the end of October, where only about 1 in 5 of people aged over 80, be they in care facilities or living at home, had received 2 doses of the vaccine. And that's about the same proportion of people aged between 25 and 49. So only about 1 in 5 of adults in Bulgaria as a whole had been double dosed, and there was no prioritization of people at older ages. And of course, we all know how much higher case fatality rates are from COVID for people aged 80 and above compared to people in midlife. Here's India. At the start of the year, when I last checked, about 18 million people aged over 60 were yet to receive their first dose, and about 31% of older people in India had yet to receive a second dose. And overall, that was about the same proportion of coverage that you see for people aged between 18 and 59. So if you're aged over 60 in India, you're no more or less likely to be vaccinated than people at younger ages. Despite this lack of coverage for older people, and I don't have data for people aged 70 and above or 80 and above, Prime Minister Modi has introduced a new phase, as he calls it, of the vaccination program, focusing on rollout for children. This is Thailand. Very similar situation, again, about less than 40% of people aged 60 or more at the end of the year had received at least 2 doses. And again, the Thai government and the Ministry of Health recently announced with the grand fanfare that they have a new phase in the vaccination program, which will be reaching out to children and providing 4th, not 3rd, but 4th doses to groups they consider to be priority groups, which do not specifically include older people. My favourite at the moment is the Philippines. About 600,000 people, as far as we can tell, older people in the Philippines have not received a single dose for one reason or another. About 5 million have only got one dose. About 6.8 million people, older people in the Philippines, are double dosed. 47 million people under 60 in the Philippines have been double dosed, so 7 times as many. And I'm excluding from that more youthful population people who are health workers. So these are people who are not health workers under the age of 60. 47 million of them double dosed compared to less than 7 million older people. Now, what I find particularly interesting about the Philippines is that the government, and particularly President Duterte, blames the lack of rollout of vaccine, the lack of uptake of vaccine, not on vaccine nationalism and the lack of doses, and we can see that we clearly do have a lot of doses, but on reluctance and ignorance of Filipinos who are resisting being vaccinated. Now, I find that a bit odd, because we can see that 5.5 million older Filipinos were happy to receive one dose of vaccine and are still waiting for their second dose of vaccine. And I find it hard to believe that the majority of those people have since changed their mind about whether they consider the vaccine to be acceptable or not. But President Duterte and the Ministry of Health and many other local government policymakers in the Philippines have gone beyond that now, not just blaming older people and people of other ages for not being fully vaccinated, but have now decided to introduce sanctions and punishments for people who cannot demonstrate they have had 2 doses of vaccine, being banned from using all forms of public transport, and being required to remain at home, often with a threat of serious force to impose that requirement. This is what I mean by global geronticide. I could talk about other countries, but a lot of countries don't even publish data on vaccine coverage by age, including Mexico and many other countries. Now, not every single country in the global south, outside of the richest countries in the world, is on my list of scandalous exclusion of older people from COVID vaccination. Brazil has actually been very effective in vaccinating older people as well as its more general population. By the middle of last year, it had reached about 98% of people aged 60 and above, and by the end of the year, it had double dosed 85% of that population. We saw that Chile as well, Luis Miguel referred to Chile as another example of what Liat might call positive ageism, where you see that in some countries it has been possible to prioritize older people. And so the argument that this is a consequence of vaccine nationalism, of low resources, of low infrastructural capacity and public health to roll out vaccines doesn't hold weight when you see that some countries have performed relatively well. Moving more specifically to the issue of long-term care facilities, again, like Leah, I wouldn't call them homes. Now the terminology that people tend to use is a facility, which is a rather dehumanizing concept in some ways. I live in a facility, but there you go, perhaps that's quite realistic. In low and middle income countries, we have to bear in mind that although richer countries are more advanced in terms of population aging, the large majority of people of very old ages, people aged over 70, live in low and middle income countries, and these are the people who have different kinds of long-term care needs. And one of the things that's been happening very, very quickly in countries like Mexico and Brazil and in South Africa has been incredibly rapid growth of care home provision, long-term care facilities for older people. So over the last 12 or so years, according to the data we have, the number of people in China living in these facilities has grown from 2.3 to 7.3 million, more than trebled. In Brazil, the data are not very robust, but from around 1,000 facilities that we knew of, and that's probably an underestimate, to over 10,000 that we're aware of today. So you can see that purely in terms of the number of older people living in long-term care facilities, this is an important issue for low and middle income countries. Very, very generally, I don't like to differentiate in a sort of binary way between the problems that long-term care facilities have in rich countries and then contrast them to what's going on in poor countries, because of course it's much more of a spectrum of experience between different kinds of countries. So I don't like this kind of binary distinction between the rich world and the poor world. But nevertheless, there are some generalizations that more or less hold water when we look at low and middle income country settings. Firstly, long-term care facilities, not surprisingly, have fewer resources. Generally speaking, multiple room occupancy is the norm rather than the exception, except for very small numbers of facilities for very wealthy older people in those countries. And often you might find 5, 6, or even more people living in very basic dorm-like conditions. Generally speaking, they have fewer trained staff and not just access to a whole range of resources that would enable them to manage the pandemic. Many of these care homes I think we could describe as being invisible because basically they don't exist on registers of any state regulatory authority. They are informal and they are underground. And when I say many, I mean possibly in some countries, there are actually more invisible care homes than visible care homes. And even for those care homes that are on the official radar, this is something we talk about in some high-income countries. It's often there's a disconnect between social care and health departments in terms of who has lead responsibility. In the case of most low and middle income countries, that disconnect is even more acute. So for these reasons, when the pandemic began to hit, and a lot of people in low and middle income countries could see that 40% of COVID deaths, as we now know, in Europe and in North America were in care homes, which is scandalous. There was a real concern that because lots of people live in long-term care facilities in the global south as well, and they're even better prepared to address the pandemic, that there was a need for some kind of specific response. And so working with a number of colleagues, we put together and started to disseminate a kind of emergency pandemic response strategy. And a bit later, we got some funding from UK government, from the Global Challenges Research Fund, to work closely with some local governments, one in South Africa, one in Mexico, and one in Brazil, to look at the extent to which that framework had been helpful to them and what effects that framework has had on what they've actually done. And I'm not going to talk about Mexico. I'll start off by talking about Western Cape and South Africa. We're still collecting data. And so this isn't a systematic review of what we've collected so far. These are just some excerpts from some interviews. This is from the manager of a long-term care facility in Cape Town, in the Western Cape, and I think it tells an interesting story. I had to beg them, those are public health vaccine teams, to come out to our facility. They wanted us to take the residents there. There was about 9 miles away. When they did come, the manager was still preparing a list of employees and residents who wanted the jab. The residents don't have cell phones, so I had to use my phone to register them. You have to be registered and apply for the digital vax passport. You have to apply for the digital vax passport. It was difficult to get hold of family members who needed to give consent. And then they, the public health vaccine team, brought members of the public into our facility where we're meant to have restricted visitors. They told the public there was a clinic at our facility, but we're not a COVID clinic. There was actually a queue around the corner of people trying to get in. The vaccine team were to come out especially for our residents, the elders, as she calls them, not the wider community. Very low rates of uptake of vaccine among their staff. And the main reason wasn't reluctance to be vaccinated, but was that getting a vaccine was very difficult for these members of staff because they didn't get priority status. They weren't seen as health workers or frontline workers. And this is a typical experience. The manager talking about her own efforts, the manager of a publicly funded long-term care facility. I went to hospital, waited all day, didn't get vaccinated. I'm going to move to the city of Salvador in Brazil, where we're also working. Now, this is arguably a setting where there was a more effective response on the part of different local government agencies, and we would like to slightly claim credit for that, in that they very much referred to this emergency strategy And one of the ways in which I think we can see some success is it's the only of the 3 locations we have where we have reliable data for vaccination rates in long-term care facilities. And that included a number of facilities that they were able to discover in the course of the pandemic. So trying to bring in at least some of these invisible care homes that nobody wanted to admit existed in the past. And I've just given you some data from a paper that came out a couple of months ago. So tremendous success. 80% of facilities had been able to provide vaccines to 90% of residents. Very low refusal rate. And I do worry that sometimes, as we saw in the Philippines, that anti-vax sentiment, or whatever you want to call it, is an excuse. And even among long-term care facility staffs, we see very low refusal rate, again 0.7% of staff, but much lower overall coverage of these staff. In 36% of facilities, only half or so of staff have been vaccinated. And that was for the same reason as we saw in South Africa, that these people are not seen as important. They're not seen as professionals. They're not seen as health workers. They're seen generally as low status female part-time workers. And we all know that that leads to cross infection across care homes, because often these largely female low-paid workers have part-time contracts across a number of different care homes, and they travel on crowded buses. They go back to live in their crowded households. They don't have labour rights, which will give them paid leave when they have coronavirus, and therefore they become a major vector of viral entry into these facilities. So that's all I can share with you at the moment, because we're still actually doing the field work, but hopefully that provides some interesting insights. Clearly, in the Global South, vaccination in long-term care facilities is challenging, both in terms of a more specific institutional context, the lack of resources and the vulnerabilities of many of those long-term care facilities, and also the lack of capacity at local government level to help them through the pandemic. But this has been occurring, perhaps more importantly, within a much wider context of what I feel quite comfortable, very sad, but quite comfortable to refer to as global geronticide. This is a statement from the Director General of World Health Organization. There's a disturbing narrative that it's okay for older people to die. It's not okay. And this is from a short paper we were able to get into the Lancet a few months ago. And this really sums up the way I feel. I'm not somebody, I know sometimes I might come across as being a little bit blunt. I'm actually quite a conflict-averse individual. I like to retire to sort of more genteel kind of academic environment. So throwing around accusations of state-sponsored, state-sanctioned geronticide might seem like unbecoming shrillness, but what else are we meant to call it? So that's all I've got to say. Jane referred to the network that I helped run. I'll put this link in the chat. Most of the material that I've used today, pretty much all of it, you'll be able to access one way or another through that site. Thank you.
And thank you very much, Peter. As I expected, real live data, and the voices of people in these particular situations. However, that doesn't change anything, does it? So I want to start moving on to having a bit of discussion about how can we move certain agendas forward? Because we all know that the uptake rate of adult vaccinations was abysmal prior to COVID. And we've all been trying from different ways to understand why it is and then to take action. So first of all, I want to go to Liat. The World Report on Ageism talked about 3 different areas of evidence-based interventions. One is policies and laws, one is around education, one is around this intergenerational drive. Can you see any of these aspects within the framework of addressing some of the inequities and lack of policies in long-term care? Can you see that as part of the UN decade?
Of course, I see, and maybe I can go even to your previous question, which was related, and you kind of asked, how come it's not happening? And I think that it's not happening because it really requires us to talk with each other. And ageism is extremely pervasive to the point of affecting each and every aspect of our life, as you were saying, the institutional level, the interpersonal level, and the individual level. And if a physician who makes decisions about healthcare priorities disregards everything that we know with regard to ageism, the psychosocial aspects of ageism, this is certainly going to color the decisions that this physician is making. And this physician can be at the top position of making decisions and policies for all of us. And I think that we see it also with the WHO, that on the one hand, there are people who are very committed to combating ageism, and other people are not as aware of it as of now. So we really need to bring the discussion between people, and education is certainly one way of doing that, through this webinar, through other educational materials, and really trying to make sure that all disciplines understand that ageism, all disciplines and all human beings, I would say, understand that ageism really concerns all of us. And I think that once we understand that, and once we understand how it affects our each and every decision that is being made, then we will be able to go back and really incorporate the idea of vaccination, long-term care, older people, and how should we frame it to really better this population and society at large, because it's really not one group at the expense of another. We've seen it also at the international level. If we neglect one group, it's going to come at us eventually, and we're all going to suffer. So the idea of equality is really, really important, and people are not there yet. So we need education, we need the intergenerational contact, as we know that people who have, for instance, positive intergenerational relationships are less ageist. We need these people to make policies afterwards that are going to affect the health of all of us and will not be ageist.
Look, thank you for your response. In the context to the decade, and I want to turn to Louis Miguel and talk about this tension across generations, because we've seen it play out in COVID, but we've seen it before as well. And I go back to the Immunisation Agenda 2030 that talks life course, but I rarely see at a national perspective the execution, the implementation of a life course approach. You know, what's the future of, a true life course approach where we can acknowledge the importance of vaccines for children, younger people, women, all the way through to older people, with the knowledge that our immunity changes as we grow older, but there is a value in vaccines. So what's the future of that conversation?
Well, indeed, as I said before, I believe that we are in a turning point, and that it is possible to move forward in the context that we are living now, as it has been shown how effective vaccination is in this population and how large the impact has been. So I think it's an extraordinary opportunity to move forward. But I don't see this issue in the conversation in the media, for example. And I am aware of this because I am in the field, and I've been working on this, but I don't see this awareness elsewhere. And I feel still in the media in Mexico, at least, the tension within the prioritization between generations, and the emphasis that is being put now in my country in childhood vaccination, which has not been addressed at all yet. And traditionally in Latin America, in Mexico in particular, childhood vaccination has been a priority. We have had a very good performance through the years until now with the current pandemic. Even these programs have suffered a lot. But I would encourage us all to see this as an opportunity to move forward.
Look, thank you for that, Louis Miguel. And I want to now turn to Peter around equity. In our work with vaccinations, we talk about prevention, we talk about access, and we talk about equity. Prevention being public health campaigns, etc. And we know that governmental campaigns assume a certain level of health literacy, which means that in and of themselves, they do not reach those populations that we need. Second, access. In certain countries, there are no mobile clinics. Everything is technological. So once again, many of the most vulnerable populations miss out because they don't know that the vaccines are there, even if they could get there. But this whole issue of equity, Peter, and we go back to Sir Michael Marmot's work on social determinants of health. Tell me why, in your mind, why the countries that you've studied, some of them, Thailand, etc., why have they almost flipped the approach to COVID? Because that's clearly, to me, a policy decision that has prevented, the most vulnerable populations from being vaccinated. What are your thoughts on that?
Short answer is, I think it's complex, and I think it varies from country to country. In many cases, I feel that what we're seeing is a prioritization of vaccination towards the wealthy, regardless of age. And wealthy policymakers in countries like India were very concerned initially that their elderly parents be vaccinated, then that they would be vaccinated, then that their children would be vaccinated, then if they have them, their grandchildren be vaccinated. So the main determinant of whether you've been vaccinated in a country like India is your relative affluence. And so this is an issue of equity, which in some ways transcends the issue of age. You can bet where you see a high proportion of older people who have been vaccinated in some of the countries I was discussing, that they will be primarily very wealthy older people from elite groups. So, if your elite status is the main determinant of whether you're vaccinated or not, perhaps it's not surprising that you see similar levels of coverage for people in their 30s or 40s or in their 70s or 80s. That's probably the best explanation I can give. I feel also that often, of course, this is dressed up in terms of saying, well, older people aren't economically or socially productive, that older people are going to die anyway, etc., etc. And of course, one can discount all of those arguments. But one very simple point to make is that if you take into account the enormous risk of death for somebody, let's say, aged 80 compared to somebody aged 40, if you vaccinate either one of these two individuals, the years of remaining life that you will generate for vaccinating 80-year-olds is far higher than it would be for vaccinating people aged 40. Because although maybe an 80-year-old on average may only survive 5 years, the risk of dying is huge if you're not vaccinated. Whereas perhaps life expectancy for somebody aged 40 is 40 years. But COVID vaccination hardly affects their risk of dying, because COVID scarcely kills these people. So even if you just want to use metrics like that, there is no basis for this. But at the end of the day, I think this is and it sounds rather sort of hackneyed and whatever, but this is the age-old story of rich and poor. Mm. And that these are countries where there isn't sufficient strength of governance to challenge that quite outrageous inequality on the basis of an obvious set of public health and greater good arguments. It doesn't exist. I'm not being held.
No, it doesn't exist. And then we have got some populations where they're choosing whether they'll have one vaccine versus the other. And that's certainly the boat of entitlement. I just want to, Xenia Shield Adlung has put forward a question about how can ageism in COVID vaccinations be explained? Is it based on negative social values regarding older persons or fears of getting older? So who would like to, have a go at that one?
Just to chip in, I think in some ways I just answered that with reference to the countries I was talking about. I just think it's self-interest. looking after you and yours, regardless of age.
Yeah. Louis Miguel or Eliette, did you have anything to add?
Sure, I could add from a psychological perspective, there is the terror management theory that talks about how we are really very fearful about facing death. And that's why, or one reason why we try to shade away from older people. And now there is a really strong reminder that older people plus COVID equals death in our mind after 2 years of really being bombarded with that. So I think this is one possible explanation for why ageism has been so prominent. Another one is the fact that, again, we are facing scarce resources. It's not like there is vaccines for everyone at the same time. And we need to prioritize that. And I think that we have seen it all along, way before the pandemic, that older people are thought to be the ones that should be last in line. They should not be consuming too much. They should not be interfering with the affairs of younger people. And it plays also in the case of the vaccines.
Do you know, Eliette, what I don't understand is we get it. We see the ageism play out. We see it every day. We see it in our studies. We see it in our environment. So how come politicians don't get it? Or do they get it and they choose not to go there because it costs too much money? And by the way, older people, assuming, die sooner than younger people. Because, you know, I've been watching the television like everyone when politicians stand up and say, it's terrible. You know, 80% of deaths of COVID have been in long-term care facilities. We must do better for seniors. This is absolutely unacceptable for anyone to say we must do better. So what are we not doing so that, you know, the policymakers, the decision makers actually take action? Is it still ageism? Louis Miguel?
Well, I think it's an issue of awareness as well. If politicians were aware of what Peter said just a few minutes before, of the impact in this higher risk population of the interventions and the economic, even the economic benefits of this, the decision comes much easily. And in fact, in many countries, at the end, this perspective prevailed, and older people were prioritized for vaccination in scenarios of vaccine scarcity, which was the case in Mexico, for example. As we were not able to get as much vaccines as we needed, we had to focus on the highest risk population, and it was very easy to move forward into that direction because of the higher impact of the intervention. But as people were aware, as we had a local expertise and a group of experts in vaccination that were aware of this and that were willing to look at the evidence, it moved forward with relative ease. When there is knowledge, when there is awareness, but that is what is lacking, what is missing in many countries around the world.
Yes, and also in many countries, this has very much been politicised, hasn't it? You know, because elections come and go. And so I've seen it in my own country, you know, that elections are coming and, you know, I'm not saying there's a direct association, but there is something playing out in decisions that are being made. I just want to pose another question. Peter.
Can I just throw in one other comment? I actually think you're not framing it right. I don't think we need to be talking that much to politicians. I think we need to be talking to other experts and academics and stakeholders working in global health. I'm just going to very quickly share a couple of slides from a different presentation, if that's okay, because I think this makes the point. And this is partly inspired by my time working in the Lancet Commission, the Lancet COVID Commission, where I was the only person in our group who was particularly interested in older people. And first it took me out of my comfort zone, and I realized, gosh, I live in such an echo chamber. I talked to other people who reinforced my views, and we all agree that this is the way the world should be. But I suddenly found myself, in this kind of situation, where most of the people were talking about a whole range of other issues. There's a tremendous focus on gender rights, and there was a lot of focus on maternal and child health, etc., refugees, people living in prisons. And actually what I realized was that I was one of the very small echo chambers, and there were some much bigger echo chambers around here. We do not influence what goes on here.
Peter, can you put it on big screen? Put it
Yes,
on.
sure.
Thank you.
Louis Miguel talked about, I'll try to. Louis Miguel talked about, slideshow.
Yep.
Talked about, you know, SAGE and WHO having no representation. It's scandalous, the lack of representation of people on nerve tag. But I think what we need to do somehow is we need to really target within the global public health community those levers and those buttons which will enable us. There was a paper that this group put out in the Lancet Public Health. I managed to get 5 lines on older people in a 14-page paper. You know, so we somehow have to break out of this.
Yes.
And I don't know how we do it, but we need to think very smartly about what the buttons are, where the levers are, because I think we spend too much time talking like we do to each other, which has its benefits, but we need to come out of our comfort zones, out of this little box over here, into to engage with other agendas.
Look, I couldn't agree with you more. And Louis Miguel and I have been at meetings and convened meetings where we have experts in diabetes, in respiratory conditions, you know, at the table, because it's about bringing unlike together towards a common agenda. So we're just into our last 10 minutes, but I would like to just follow up on a couple of questions. Maria Pelosa, what about the fundamental problem of co-modification, costs of health services? Perhaps ignoring the vaccination needs of older people is being treated as costs for government, regardless of the data from health and medical professions. Goodness, that's a complicated question.
Well, indeed, when we look at the benefits in terms of healthcare resources utilization for older people that have been vaccinated against influenza or pneumonia, I think that it is self-evident that it's worth the investment, and that is what, at least in my country, has allowed us to move forward.
So, look, thank you for unpacking that so beautifully. Just another question about gender. Do we have any data around older women, older men in times of COVID and in long-term care? Liette, do we have any data, and what is it telling us?
Well, I think that this comment that you saw in the chat was kind of saying it, that we know that women are less likely to have an informal and unpaid caregiver. And this is why we know that women end up more frequently in long-term care settings, where they live longer, and they often have more medical conditions, and all of these things do make them more susceptible to ageism, especially in long-term care settings. Nonetheless, we know that actually men are the ones that are more affected by COVID-19. Yes.
Look, thank you for that. And Louis Miguel, I'm just coming back to you around healthcare professionals and that beautiful chart that you had, you know, that really just traced, you know, the pathway really. And, you know, in many countries, you are a rare breed as a geriatrician. So, you know, and we also know that healthcare professionals, you know, need to be updated with, you know, information about vaccination. To what degree is that a problem in trusted resources for older people? Is that one of the barriers?
Absolutely, that is one of the barriers that we face day to day here in Mexico and in Latin America as a whole. I believe you're absolutely right.
Yeah, and Peter, you know, from your work, to what degree are public health messages, you know, assuming the same level of health literacy, or do we have it different?
Well, I think we do have to be very careful. but I don't think the levels of health literacy of older people in Chile, in Brazil, or in Peru, which has actually done quite well, are less than they are in other countries. I don't think those 5.5 million older people in the Philippines who received one jab and are being threatened by the government with all these sanctions. That we have to be careful. There clearly is, it is an issue to some extent, but it is also an enormous excuse for massive policy failure. And so we have to talk about it, but we have to be careful how this is interpreted.
Look, thank you very much. As we come to our close, I can see that there's some resources that have been put in the chat box, and we'll gather those all up. I want to thank our speakers today and come back to you and ask for your key takeaway message while I actually just talk about how fortunate we are to have been able to deliver these 3 webinars with the unconditional support, from Pfizer through an unrestricted grant from Pfizer. So we thank Pfizer for that. And let me just tell you what the objective was for today's webinar. The purpose was to improve our understanding of the impact of institutional ageism on the health of older people in long-term care facilities, and to highlight the importance of routine immunisation as an intervention that saves lives and money. It is a very complicated conversation, but what we've tried to do today with key experts is unpack, some of the real life experiences that are happening in our world today, and shine a light on them in terms of what is the next policy change, what is the next step in policy development. And to that end, I want to just share with you that the 3rd webinar in this webinar series will be held in March, and it's entitled Global Equity in Vaccination as a Sustainable Solution Toward a Healthy Global Population. So join with us in that webinar in March, and I want to thank Anushay Khan and Berenice Anaya and the comms team for being able to put together this brilliant webinar. So I'll go backwards. I'll talk to Peter, then Louis Miguel, and then Liat for your takeaway messages. Peter?
Yeah, thank you. Just very briefly, as Jane said at the start, I run this network, and I've just shared the link again. It is completely unfunded. I don't get any money for it. It's all done by volunteers. We're not getting very many contributions. We have a very influential blog series. We do webinars. Please, if you have anything, even if it's relatively rough and in note form, send it to us, because the whole ethos of this network is to get information out there quickly, because we can't wait 2 years for academic papers to be published. This is another means whereby hopefully we will be able to break down some of those barriers. Thank you.
So Peter, you can count on us. We'll put it out in our social media and our voltage and continue to push it out. So thank you for your contribution. Louis Miguel, what can we take away from you?
Yes, thank you. Well, I think that information is key, and access to this information is essential, and we need a real-time information. In Mexico nowadays, information about COVID in general is easily accessible, but particularly about the issue of vaccination, it's been very difficult, even for us researchers within the government, trying to access the database. We have been there for 2 months and haven't been yet able to get access to this database. I think it's absolutely necessary, and we are working towards the development of an information platform within our institute, easily accessible to all the nation, to people of all, not only for experts, to be aware of what's going on with aging and health in Mexico. And WHO is leading such an initiative as well at a worldwide level. And I think that will be key for being able to reach success in this and other issues of aging and health.
And thank you, Louis. And perhaps you could give us those links and we will also promote them. Thank you. Liat, you have the final word.
Sure. So I think that all 3 presentations stress to a certain degree the fact that it's not ageism alone. It's often ageism in intersection with other things. In this entire symposium, we were talking about ageism with regard to older people, but it's not only older people. it's older people in long-term care settings, and the experiences of older people in long-term care settings are quite different from the experiences of older people in the community. Another theme that came up was, again, it's not ageism in a certain all over the same way. It's ageism which is manifested differently in different countries, depending on the socioeconomic status of that country, depending on other traditions that are going on in that country. And one of the questions that was raised about gender, again, it's not only ageism, it's ageism in intersection with sexism. So we have to be more complex in our thinking about the problem.
Thank you very much, Liat. I think one of the key quotes that I think Louis Miguel talked about was ageism has multiple faces in our society. And we are one of those that can mirror and can push out and create change in the narratives, the research, and the connections we make. And finally, this about coming together, unlike together, that we need to reach across disciplines and sectors to ensure that we have a common agenda, but come to it from different places. So thank you once again for being with us today. We look forward to March, and thank you to Pfizer for its unrestricted educational grant to enable this webinar to happen today. Thank you very much. Be well.
Thank you.